All right, so let's get started. Thank you all for joining us today. Today we are hosting a webinar on supporting and understanding tobacco cessation programs in public housing primary care. And this is the second session out of the two-part webinar series. This presentation is also presented by the National Center for Health in Public Housing and the National Healthcare for the Homeless Council. And now I'll pass it on to Elena.
Hi, everybody. Welcome. I think I'm seeing some names that I remember from last week, so thank you for coming back. It's really always appreciated, and because this is a two-part series, I think that foundation we provided last week hopefully will help with today's discussion as well. So my name is Elena Boyer, pronoun she, her. I am Senior Director of Programs at the National Healthcare for the Homeless Council. And I'm just going to review our agenda today. This will be an engaging session, so we would really love for folks joining us to participate. And we will share with you some ways to do that. You can do that through the chat. But since we have a small enough group, I think, coming off mute would be also very manageable for us as we have a back and forth in conversation. So be ready, and we just welcome any thoughts that you all have. So we'll continue with our introductions, a little bit about our organizations. I'm going to do a recap of session one. And then we will dive into a case study that Dr. Lombardi will be sharing with us. And this is where we'll have interaction, where I will also be a participant, as well as our subject matter expert from last week is also still with us and joining us today. So I'd like us all to acknowledge Anne DiGiulio. And then we will share some resources at the end of the slides. And then we'll go through an evaluation that would be really helpful for us as we assess the series. And as a note, we will be providing these slides to you and the recordings following these two sessions. Next slide. So again, my name's Elena Boyer, and I've already kind of introduced my title, but I do work for the National Healthcare for the Homeless Council, which is a national training and technical assistance organization that is really focused on the population of those experiencing homelessness. Our mission is grounded in human rights and social justice. The National Healthcare for the Homeless Council mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. We also have our disclaimer at the bottom of this slide, as this is a webinar funded through our cooperative agreement through the Health Resources and Services Administration. Next slide, and my partners can introduce themselves.
Yep. Thank you, Elena. And also, this is just some information about the National Center for Health in Public Housing's mission. The mission of NCHPH is to strengthen the capacity of PHPCs, health centers, and other health center grantees by providing training and a range of technical assistance. And the information or content that is presented today is 100% financed by this grant. And this is just a brief overview of the NCHPH team. We have our program director, Bob Burns, chief medical officer, Dr. Jose Leon. We also have our director of research, Dr. Kevin Lombardi, who is in the line today. He's going to provide another introduction about himself. And myself, Filipina Sandoval, I'm DTA manager. And not with us today, we also have Chantel Murray, who is our communications manager, and Jimoke Oladipu, who is our health communications and research analyst. All right, and Kevin, would you like to introduce yourself? Oh, you're muted, by the way.
Hi, everyone. Dr. Kevin Lombardi here again. Medical doctor and epidemiologist with a focus on disadvantaged communities and getting them the services that they need. And we also have our medical director on here. So, Jose, I'm going to ask you if you could briefly introduce yourself, because we're going to be yanking you into this case study in a moment.
Thank you, Dr. Lombardi. Hello, everyone. My name is Jose Leon. I am with the National Center for Health and Public Housing. Happy to be here.
Back to you, Fide.
All right. Thank you. And now passing on to Elena to go over the recap.
Yes, I would love that. And just before I do, and Julia, would you like to just say hi? Because you might be being pulled in too for a little bit and give a reminder of folks of your background and who you are.
Sorry, the mute button is, I'm struggling with the mute button today. Yeah, my name's Anta Julio. I am the Senior Director of Tobacco Cessation and Health Policy at the American Lung Association. And I'm very excited to answer questions you may have held over from last week and then participate in the discussion with Dr. Lombardi and the rest of the team. So thanks so much for having me again.
Absolutely. So excited. I think it's going to be great. So just to reorient folks, or if you're joining us this time and missed the first session, which again, those slides will also be made available to you. Just to go over what we did in last week's session was really kind of laying the landscape and setting the stage for what does smoking cessation and smoking trends and tobacco use look like in folks experiencing homelessness or folks that are within residential housing. So we did provide some data and findings backgrounds from both of those perspectives presented by myself and Dr. Lombardi. And then, as we've said, our subject matter expert, Anta Julio from the American Lung Association, shared a lot of very important information around policy and what to expect. And so we'll be sharing those resources with you again. And so that's where we spent our time. We also engaged with you all where you all let us know kind of what things on the horizon are most concerning that we need to be thinking about. So we are using that information to form the conversation today, as well as what is coming up in a podcast that we will be working on for the spring of 2025. So without any ado, let's get into this interdisciplinary case example and practices. Dr. Lombardi?
Okay, next slide, folks. So we are going to be stepping into a certain type of interdisciplinary conversation called a case review. Now, this is based on something called the interdisciplinary model, which is the best way to get multiple perspectives on patient care quickly and to make decisions. Where we see this is in hospitals, primary care centers, physicians work with nurses, work with social support personnel, and administrators to manage patient needs. You all do this in your work. You're a part of it even if you're not communicating with it. If you're providing social support, you are a part of the pipeline. So today, we're going to take a patient, see him in the exam room, see him in social support, and take the perspective of the patient's chronic diseases in the context of tobacco use. So we're going to start here, and I'm going to read the case, and we'll start with we'll go through questions, and the conversation will go from there. We've got Mr. Lavrov. He's a 52-year-old man who presents for a sick visit due to respiratory issues. He has a past medical history of hypertension and behavioral health history of major depressive disorder and generalized anxiety disorder. Mr. Lavrov also has a history of opioid use disorder. Now, I ask you to all take a second and think of those diagnoses that patient is walking through the door with, and what those all mean, what the story could be behind them. Next slide, please. Okay, now the medical record exam. Past medical records indicate that Mr. Lavrov was last seen at this clinic in October 2022, and that he has not utilized opioids since his completion of a rehabilitation program in 2017. Great. His records also note that he's a smoker, and he was noted to have smoked a half pack a day intermittently throughout his adulthood, with a total of 21.5 pack years smoking history. His current smoking status is unknown. Next slide. So let's take a look at his vitals here. And Elena, I'm going to ask you to read these and tell us what's popping out to you.
Absolutely. So in these results, I see that his blood pressure is 178/98, coming in at a weight of 205 pounds. His heart rate is 92 and his respiratory rate is 18. Looking at his previous vitals taken in 2022, we can see some changes here. So what I have noticed is, in addition to these vitals, is that we do seem to have a complex patient, someone that's dealing with what we often call in our sphere, trimorbidities. So someone that has a chronic disease. We saw that there was behavioral health, so a mental health issue, and we saw that there was a past use of opioid use. So we're looking at substance use as well. So this is a common patient that I imagine is common around among individuals who are in residential housing or persons experiencing homelessness, or even the larger public. Looking at the vital signs, I'm seeing that his blood pressure is high, higher than what it was in 2022. His weight seems to be high, so maybe in the or the obese category, maybe. And I see that his heart rate is high, so it seems to be tracking with the hypertension that we're seeing as well.
Yeah, yeah. And you know what, in the context of a patient with a documented history of hypertension and a documented history of taking medication for it, I'm thinking medication and compliance, and I'm thinking of in the context of patients' comorbidities, that this patient may be undergoing a lot of stress, physical and psychological. So let's see what we have next. Next slide. Okay, and this is for everyone, panelists and the group. We're going to use a dinner table slash podcast style system here. Just speak. And for those of you in the audience, you can raise your hand if you want, and we hear your voice. We're going to stop talking. So, I'll pick on I'll pick on Anne for a second. What are your impressions of this patient's medical history? What's sticking out to you?
Well, there's clearly something going on with Mr. Lavrov, and I'd love to see if there's a common cause of that. If there's anything around social determinants of health that is, and we know that he probably has some housing instability in his past, and so kind of does that relate to any of this? Is he having trouble getting, like we say, in non-adherence to medication? Is he having trouble getting his medication? Are the copays too high? Is there a prior authorization he doesn't have? Kind of how do we work through some of those things? Those are kind of some of the first things that come to mind as we look at some of those, and how can, as the healthcare system, we fix those pieces. Again, I'm a policy person, so I'm looking at this through a policy lens, but that's where I'm at.
But you know what? The policy is baked into the infrastructure, and let me connect that for you here, Anne. What you're saying in policy language is this patient needs to be networked to social support, and his individual social needs need to be addressed appropriately. And clinically, I couldn't agree with you more. And we have our, thank you for that. And we have our attending physician on the line here. Jose, what's popping up to you? What's a priority for you with a patient like this?
Thank you, Kevin. Evidently, the patient has multiple comorbidities, as Alina mentioned. And from a clinical perspective, I need to find out what's going on with his blood pressure, whether or not the patient has been compliant, has been taking the medications the right way, whether or not I need to adjust medications. And the other thing that is really important to link is that the patient is also a current smoker. And we know that some of the complications when you are a smoker is that you can have cardiovascular diseases being worsened by the use of tobacco. So I also agree with Anne regarding the social determinants of health. If the patient is not taking his medications, we need to find out whether there is a social component, anything that is unrelated to his clinical condition, but related to any social determinant of health. So this is an interesting case, Dr. Lombardi, that we can dissect.
So now that we're talking to the primary care physician, let's get into the primary care context here. Next slide. So prior to his exam, this facility's protocol is the patient receives a screener, an SDOH screener. They receive that right after they get their vitals. It goes into the examination room. And this is what it is. Now, I'm going to ask, Fide, you want to read this one for me?
Sure. So based on this questionnaire, the patient in the past 2 months um, did have um, did have smaller meals or skipped meals because they didn't have money. They also did experience homelessness and were worried about where they were going to be in the future. They also did worried about paying for their utilities and their gas, electricity, phone. They also did find trouble paying for a ride or transportation. And they said no, that they didn't have any needs for daycare.
Okay. So I'm seeing that we have quite, just in these 5 questions, we have 4 positives already, and each of those are going to need individual social support interventions. So thank you, Fide. And I'll ask you to go to the next slide, read that for us, and then as you're going, tell us what's popping into your head, what red flags that are showing for you.
For sure. So over here, it also shows that the patient is unemployed and doesn't have regular income. They do need help finding a better job or just a job. Also, they say that they don't need help with more education. They said that they're not concerned about somebody else in their home using drugs or alcohol. Well, they are experiencing homelessness, so kind of shows why that wouldn't be a concern for him. And then the patient also does feel unsafe in their daily life. And there are no concerns for anybody abusing the patient. Some of the things that do pop up in my mind when I read this is about the social risk factors that this patient is currently experiencing, such as like not having regular income, needing a better job or just needing a new job, experiencing homelessness, not having adequate food available as well. So those are some of the things that
You speak to a very complicated social situation. And when I see something like this, I need a consultant. So I'm going to ask Elena, from a social support perspective, are you seeing anything on this page that pops up to you? And what's coming to the forefront in your mind?
Yeah, absolutely. Thank you, Dr. Lombardi. I think from kind of the whole person care and supportive side of things, and I agree with Fide, a lot of those things that she mentioned popped out to me. We saw food insecurity, we saw instability of housing. I think what's interesting here is that this person feels unsafe. And one of the things that could be happening is that if this person is unstably housed and maybe not currently homeless, yeah, it can be very unsafe to feel that you might get an eviction notice at any moment, or a bank might be coming to foreclose on your house any moment, and your items and everything that you own will be in the front of your yard. That is a very unsafe feeling, and not knowing what to do next. We know that folks experiencing homelessness, the experience of it is traumatic on its own. So I think there's a lot of triggers here that could be playing into some of his riskier activities that are coming up that we're seeing in his physical and medical history.
And I'm seeing you itching over there, and I'm wondering if you have an opinion on this particular issue as well that you can add to the consult.
Yeah, I mean, I think one of, as I'm seeing this, clearly this person, and again, policy person, so please take what I say with a grain of salt. But, I mean,
We're the policy consultant, so give it to us in your
fair.
language.
But, I mean, I think this kind of speaks to the need of people who are in situations like this whether, however they got there, really need help getting, that people want to do well with their lives. And this individual is really clearly struggling with a job and with income. And I think if this person had more income, they'd be able to help at least get to a point where they could get started. So as I see this, doesn't need more education. He seems fine with that, but like he does need a better job or a regular job or something. And I'd imagine if he had a regular or a better job, he'd probably have some ability to pay his rent and to buy groceries and all of that. So that would be my kind of takeaway from all of this. I don't know the unsafe.
I have a question for you, Anne, because
Yep.
from the policy perspective, we're talking about a patient with diverse social needs and a patient. How can we really expect someone to go to be able to
Oh,
quit
yeah.
smoking when they're going from this? On the policy front, what are the priorities for social support and that could help someone like this? What are you all talking about?
So I will be perfectly honest, we're the Lung Association, while we're concerned about making sure everyone has access to quality and affordable health care and can live in a smoke-free environment and has the resources they need to quit smoking. There's a lot of this that's a little bit beyond our purview. And so I'm just kind of having fun with this and I hope that's okay. And I don't mean to be crass because this is a very serious topic, as we all know. But I think making sure someone is in a stable place can help them, both quit, if this person has a history of an opioid disorder, I believe, if I remember correctly, and smokes. And we know that those types of comorbidities go together. So if you can get one under control, you can probably get both under control. And having a stable home or having a stable job can help some of that. And so, not to say to you don't have to worry about quitting smoking or, getting your blood pressure under control until you have a job, because, we want to make sure that this individual has the ability to do those things in the future and isn't dealing with worse health outcomes. But to make sure that we're, inclusive of all those needs. An individual has to choose to whether or not they want to quit smoking. It's not something that you can hoist upon them. So that's kind of where I'm at.
And this is where we see the overlap between the policy and the clinical realm. And what I'll say is thank you for that. And we're an interdisciplinary team here. And just like in the hospital, if you've ever sat in a hospital board meeting, what you'll have is a smattering of physicians, administration, accounting, and so forth. And patients come up because they're related to legal cases, they're related to QA, QI. And so we're often, when we're talking about patients, we need to be able to find that place where we can discuss them with similar language. So that's what the interdisciplinary team is. For those of you at your health centers, I encourage you having those interdisciplinary conversations with your colleagues, discuss cases, discuss the outcomes. Now, I have a question for Dr. Leon, if you're available. When you're, as a primary care physician, if you're seeing a patient with hypertension and a lot of social risk factors, what comes to mind for you?
The beauty of health centers, Dr. Lombardi, and how they have developed the patient-centered medical home to address fragmentation. If this patient is seen in a private setting, probably the patient is going to receive treatment for his hypertension, is going to receive some counseling for tobacco cessation, and the substance use disorder will be reviewed just to make sure that there is no relapse. But all these social determinants, probably the patient is not going to get anything out of it. So what health centers are doing, addressing and making sure that they understand all the healthcare needs and social needs of the patients is what really strikes me. It is very important to make sure that we have all the background information that we need as clinicians to make sure that the patient receive better services, and the outcomes are going to be much, much better.
You know, I'm so glad you mentioned that, Dr. Leon, because I'm thinking of when I've been in this clinician's position and I get to see 15 patients in a day, and each of them, if they are if they are in our medical record system, I've got to click a box saying that I discussed tobacco cessation with them or ask them about their smoking status. Now, I've got 15 minutes to address that and everything, a single medical and billing issue. So these are time-consuming conversations, and professionals in the exam room often don't have the time to do it. So this talks about the strength of the social support personnel, and I'm sure when you were thinking about this, Jose, you're thinking this is a person that you're going to do a referral for.
Yeah, I mean, if I have the resources, the resources in-house, this is something that we are going to discuss internally and work on making sure that we work with our other specialists on social workers and all the team that we have in place. If not, as you said, there might be the need, for doing a referral to this patient. But in reality, a complex case needs the integration, of all the services that we can provide in a healthcare setting.
Mm-hmm. Mm-hmm. Thank you, Dr. Leon. Elena.
Yeah, I don't mean to interrupt, Dr. Lombardi.
You go. This is what the conversation's all about here. Interrupt away.
There was a great question, and I'll ask Bob if he's available to come off mute. Otherwise, I'm happy to read it for him. But just something that Jose and something you both alluded to, and something that we think about a lot is sometimes, you know, in-house in a health center might not have the right things that they need or expertise. So partnership building within your community is so important. So working with a lot of those housing navigators or shelters or places where there are food pantries that those social workers or community health workers can then refer them to is really important too. So just thinking about as you're building out these programs, or as I would think about is, making sure that I'm making those community partnerships that I would need to address any of these kind of items that come in. But Bob, would you like to ask your question?
Sure, can you hear me?
Yes.
Okay, it seems almost certain, at least from what we read in the case study, that Mr. Lavrov is experiencing some form of social isolation, which is probably contributing to his smoking addiction. And I guess, how do you address social isolation in a patient experiencing homelessness who may have lost contact with his family and doesn't have any kind of support? Because, often when somebody is going through a cessation process, that support is really critical. So how do you make that happen when this fellow has so much going against him? And on top of that, and I think you just started touching on it, but what resources are available to the health center, either within the health center or through partnerships?
Now, Bob, I gotta tell you, when I write these case studies, they're people. And this person, Mr. Lavrov, everyone who's been in primary care has met him a dozen times every month. And these are often sad stories. They're difficult to hear because these patients are almost always isolated in some sense. And you find that out by calling relatives when they're in the hospital and so forth, and finding that they just don't have anyone. And when I think of that, and I think of how limited we are in the exam room, there's no intervention for me for homelessness for loneliness and isolation in the exam room, except my social support personnel, and making sure that this person is working with the CHW. That's where we can see the strengths of social services. This is a person that, Narcotics Anonymous is a great way to start. This is a person who may be able to participate very well to a community like that, given that they've been off of their offending agent since 2017. This is something where we see our CHWs shine, and being able to link someone to those resources can help provide that social support to address that isolation directly.
Okay. Yeah, great.
Jose, did you have something to add about that, sir?
One of the important things that we need to consider here, and this is related to the question that we just got, is what triggered what? In other words, was social isolation, as Bob mentioned, the cause of, smoking in this particular patient, or depression, or vice versa. It was all these comorbidities the cost of social isolation. But just to answer his question, health centers have a great variety of partnerships, and they also develop uh, groups where you can have conversation with patients that have or are experiencing similar conditions and similar experiences. I think that this is a really good start for someone with social isolation in a clinical setting, to have a group of patients, a social group of patients experiencing the same or similar comorbidities, so they can start sharing the issues and what others have done to address those issues.
And that's what's going to be in Dr. Leon's note to the CHW he refers to. And that's where you'll see the connection. And that's where you'll see the rubber hit the road. Thank you so much for that, Dr. Leon. I'm going to ask that we go to the next slide because there's some questions I'd like to pose to the group. Fide, I'm not seeing the slides.
Okay. Can anybody else see the slides?
No, ma'am.
Yes.
Oh,
Okay. I'm sorry. Yeah, so
oh, well, I'm sorry. Excuse me. So here, I'm going to pose this to the group. We'll go hands first, and then I will cold call. What is Mr. Lavrov's STO? So, excuse me. Let me move my window so I can see here. What in Mr. Lavrov's screener indicates he may require STOH support, and how could this support be delivered? Plain and simple. Let's give a few seconds for hands to go up or for things to go in the chat. And Fide, you're my selector for this.
okay. All right. So first question, what in Mr. Lavrov's SOH screener indicates he may require social support, and how could this support be delivered? If you are from a health center, I encourage you to also share any best practices that you may have on how you would help this patient. You can also put that in the chat, or we will also unmute your line. Or if you're not from a health center or from any other organization, please also share with us.
Okay, Fide, let's go back a slide, and I'm going to pick someone from the audience. So if you can't talk, let me know. Otherwise, we'll unmute you. Craig Mendoza, are you available to answer a question about this patient?
Yes. Can you hear me?
Yes, sir. So I've got the STOH screener in front of us. Could you first please introduce us and tell you who you serve and how, and then tell me what comes to mind?
Yeah. So my name is Craig. I am the Evidence and Evaluation Coordinator at the National Health Care for the Homeless Council. And I think for me, when I look at this this list of things that the client is struggling with, I think for it really just stands out that he needs someone to be there with his support. One thing I was going to bring up as well is I know a lot of people will use tobacco as almost as a coping mechanism for other concerns that they have. And so trying to maybe link him with a caseworker, social worker, someone that's in the community that can help him tackle the other concerns that he has, because while the tobacco use is a concern, it also ties in so much with all the other concerns that he has, his unemployment, his depression and anxiety, his hypertension. It's one whole system. It all ties into each other. So trying to just get him connected with community support, a community center that can link him to getting connected to other social supports.
100%. And may I call you Craig?
Yes.
And Craig, when I hear you say that, and I put that into my thoughts about protocols, I think this person needs to see a CHW. That process, that's the action that points me to, and that's because each one, as you described, a network of all these different social needs and how it interacts with that network of clinical need that the patient's experiencing, and these are the same thing.
Mm-hmm.
We need to have each of these individual social needs addressed in order to give the patient the support he needs. And if you have a CHW available, you have it to give. So that's the key connector for me there. And I thank you for your input. Do you have anything else you'd like to share about this patient or your constituents or what you do?
No, I don't believe so. That was really the thing that stood out to me. And I know, especially as we've had some people speaking about policy, is that could be a big component of policy work is advocating for communities to have community health workers and medical social workers more involved, because it is more than just getting them the medical work that they need, but advocating for them to have individual case plans and caseworkers, because it is the social determinants of health. It is this whole system. So that's another way we can advocate to get them the care that they need.
And I will say that before I call our next participant, that that this saves money for health centers. When a patient like this is socially supported, their outcomes are better. It saves money in health utilization of resources. It saves money in just the efficiency of how to take care of the patient. It saves everyone energy, pain, and money when you can give a patient social support. So just on a mathematical level, it's a good thing. So thank you, Craig. And I'm going to ask Lakai Hamilton, are you able to join us and introduce yourself and who you serve?
Yes. Hi, can you hear me?
Yes, yes.
I'm Lakai. I'm a community health worker. I work at Charter Oak Health Center.
You're our favorite type of person. Who could you tell us about the constituents, the patients you serve? Anything that comes to mind?
Pretty much this case study, honestly.
Okay, so you're the expert now, and you mentioned something that is at the forefront of my mind, and I really want to know what you're thinking about it as a community health worker, and it's behavioral health. What's going on in your head? What's percolating in there?
Because it seems like this person doesn't have anyone to talk to. They don't feel safe where they live. There's a lot going on with them. And so usually a lot of my patients end up like signing up for behavioral health, and it actually helps them a lot. And then eventually they join like group therapy. And some of them even like become friends. So you have someone to talk to. You kind of build like a support system with people who are kind of going through the same thing you are.
Mm. Yeah. So there's a lot there, but I want to bring up a couple of things that you just alluded to. One, the social support, and I think that goes to what Bob mentioned, and this is connecting to what Dr. Leon mentioned as well. Is this patient would do really good with a peer support group that was perhaps related to one of their diagnoses. Perhaps Narcotic Anonymous comes to mind, but also patient advocacy groups for his behavioral health or mental health diagnoses. An isolated patient could do a lot from meeting others that are struggling with the same things. Is that kind of what you had in mind process wise?
Yes.
Okay. So I'm going to say, you said that this patient is a patient that you see. How often are you seeing individuals that are struggling with these behavioral health issues and chronic health issues at the same time?
Um, I'd say on my panel right now, I can think of maybe like 4 or 5. And so it's hard, but it's behavioral health honestly really does help. Like, I help them, we try to find housing, schedule appointments, find resources for like different food and things like that. But behavioral health is really helping a lot of them.
Mm-hmm. Mm-hmm. Well, I'll thank you for that, and I'll say something too. From the perspective of a physician, if I'm sending someone to you, there's a couple of things I want to accomplish. One, I want these things addressed because I can't address them here.
Yeah.
Two, especially if I've got isolation on my mind, I want them to talk to someone who cares. And the experience of working with a CHW, and this isn't just me, this is what the research says, is independently therapeutic. Meaning, as soon as you sit down the patient with the CHW and they have a conversation with them, even if nothing happens, you have improved the patient's outcomes statistically. Because that emotional connection, that bond you make with the patient is something they do not otherwise get often in their lives, and they do not get in the healthcare system. So, that's something I'd like you to consider, because I know that CHWs don't always see that, but we certainly see that from our end because we see the patient after they have spoken with you.
Okay. Wow.
So thank you for your service to you and all the other CHWs out there.
Thank you.
Okay. Anywho, now that I'm running out of espresso, let's go to the next question. Okay, and next slide, please. I'm gonna manage mine a little better here. One moment. Okay, so we're now to patient treatment. Mr. Lavrov is treated by his provider, his physician. Upon physical examination, he is noted to be tachypneic, breathing like this, and to exhibit posturing, sitting like this, hunched over, like that. His reflexes are noted to be reduced, reflex tests that tells us weak muscle tone. And he had a weakened gait. He's struggling to walk. Mr. Lavrov is noted to be thin in appearance and exhibit a prominent barrel chest. And when I mean barrel chest, and all of these things are characteristic of a certain diagnosis we're getting to, it's the chest would be very, very wide, very elastic, and his inhalation would be very restricted. Next slide, please. I've seen a lot of this condition. Next slide. Oh, yes, perfect. Mr. Lavrov notes that within the last 6 months, he's developed a persistent low-grade productive cough. He adds that it's worse in the morning and it's productive of copious yellow sputum. Also, the patient has begun smoking again. Okay, we've got a sputum coming up. Barrel chest, sputum. If you're in the medical field, you should be thinking of a certain diagnosis now. Next slide. So, how has Mr. Lavrov's smoking impacted his chronic diseases and physical symptoms? He has a new chronic disease. I'll tell you that. I'm not going to tell you which one it is yet, but he has a new one. But when you see this patient with his diagnoses, how is that smoking impacting those diagnoses? Mental health, physical health, what have you? So I'm gonna wait for hands and then pick on Elena to tell me what comes to mind for her.
Well, we're waiting on hands. I kind of just felt really heavy in my heart for this person because from a social lens, I'm related to I would feel a sense of hopelessness. Like just one more thing. Like, why is this one more thing that's happening? And so and feeling hard to breathe, in light of all of these other things that are happening in my life, like how do we handle, how does this impact mental health or behavioral health or just behavior in general and desire to want to be a compliant patient? It's just, so I'm thinking about all of those stressors for them. But I definitely, and I feel like that, I think it increases depression. I think it's, I can't handle one more thing. And so I imagine it's, as a physician being thinking about, is it going to be hard if I create an intervention or something for this person to be able to maintain? How can I provide intervention or treatment where we're not adding one more thing? So those are the things that are kind of coming to my
So
mind for that whole
complexity.
person care.
You're concerned
Yeah.
about complexity of managing this patient, and I couldn't be,
Yeah.
even on a medical sense, this is a difficult patient to manage. And the unfortunate truth is, to a certain degree, this is the average guy walking in the door. And in certain places, I know where I trained, it certainly was. He'd be an easy one, but these are complicated patients. Don't let the fact that there's a lot of them it lets you lose sight of the fact that this is a very, very serious issue. It's just that, unfortunately, most of the patients that walk in the door these days are very, very difficult to manage, just mathematically based on the number of their diagnoses, plain and simple. And when I'm thinking of what you're saying, and I'm thinking of a comment I see here. Abera, are you able to join us? Because you're asking about family and social support and caseworkers, and that's kind of where I'm going as well. Are you able to introduce us and tell us what you do and who you serve?
Hello, can you hear me?
Yes, Abera, could you? It's good to see you. Do you mind introducing yourself, please?
Yes, my name is Abera Kalacho. I work for Soap Health Services. I manage government funds, SCL, which is Supportive Community Living Funds, housing homeless people. And the reason I was saying family support means family is really important. I know this is individualistic society, but you need someone to talk to. What we do in our case is with our homeless people, we pay their rent and stuff like that. Number one, we focus on their health, and we have behavioral health, and we have medical services here, and we have mm, substance use treatment too. And we have case workers in case we have housing for them, because sometimes they destroy the house or they make it like homeless shelter, and that will create a bad impression with my landlord. So, and they might be evicted, and if the neighbors complain, the landlord complains. It's really hard to do that. But if they have family support, um, that would help a lot. Some of them even don't know where their families, but we have here their program. They actively engage in their program, and we have ITCD program for the drug treatment, and we have case workers. Really, um, most of the time I see on the national webinars is they're just housing individuals, but it's not housing. You have to do follow up if they are maintaining stable housing, and if they are not doing drug, or if they are not making party or what. In my program, which I manage, is number one, they're gonna sign a lease. Uh, I don't sign the lease, but depending on their income, if their income is real low, they might contribute $40, $50. The rest, as you know, the housing, I don't know in your state, I'm in Kansas City, Missouri is, the fair market rate is 1183. So with someone getting 800 or 900, it's impossible to manage it. So I help them with the funds the government gives, and we have department, employment department too, so that they can get themselves busy, because idle hand and idle mind is dangerous. So we make them busy coming to apply for job and taking them to job, giving them incentive and stuff like that. Otherwise, it's really hard. I see with this individual, and I mean, it's not just giving a house. I mean, I know housing is number one priority, but they can get food. We have a lot of food pantries, honestly to say. This is nice place to, I mean, get assistance, but they want direction. I mean, someone who helps them. And we have CRC meeting, which is a community resource connection from Kansas or Missouri. We monthly we meet together and we help people who are homeless. But it's tough when you are dealing with a human being. It's not like you train an animal. So that's how it is.
I couldn't agree more, Abera. And if I may say, first of all, thank you for your service to your community. And
Sure.
I loved hearing your program descriptions, because that is a very scientific system that you have there, and how you're linking your patients to services and what services are available. So I'll tell the group, take notes, because that's how a very comprehensive social support system is created. So well done to you and your colleagues, and thank you for your service. And the thing that really came to me when I'm a physician and I'm in the exam room, and I don't know these things. So let me tell you, clinical people, get onto the phone with the Iberas in your system, the social workers, the representatives, because they will give you collateral that will save you a lot of time. So the conversation should happen. And I'll say another thing is, the patients are complex. And every time we get a perspective from someone who knows the back channel or knows the infrastructure of how things work, that complexity becomes more clear. So thank you for giving us that.
If I can add
So
something,
I'm sorry,
can I add something?
please.
Sorry, I talk too much, sorry.
No,
That's
we're
because
appreciative.
I see my clients are just, I treat them the way I want to be treated, and they are human beings, period. But what we do is, honestly to say, with our homeless people, going through a lot of ups and downs, and they need someone to talk to. And we have here, I don't know in your state you are dwelling in, we have transportation free, okay? And we have our agency too. If they are away from catchment area or something like that, we will arrange transportation for their medical or behavioral appointments. And the case workers reminded them, told them, and if they cannot, just engage them in conversation so that they can come get either medication or injection or stuff like that. Even medication, our case workers, they pick the medication up and they deliver to their houses. And for food, they just pick them up and take them to the food pantry. And yeah, they engage in really nicely. I mean, if it's helping, you have to help to the point. I know it's not easy, but we have to make at least change. I know when people get assistance, sometimes they forget, and I just tell them, hey, you never know what will happen in the future, and you have to save some money for the rainy day, because if something changes, then if the funds stop, and you have to start working. If you are receiving Social Security, you can work 20 hours a week, and so that you don't forget your benefits. And there are a lot of things we can engage. And number one is really housing. Number one, housing.
You know, Abera, again thank you so much for your service and for giving us shining some light into the experience of a CHW. Thank you so much. And I will add that this case was designed to last into as long as we wanted to talk about it. So I'm going to get to the diagnosis so we at least see this. because this is where the medical stuff, we got to give Dr. Leon the end, or he's going to be calling me as soon as we're done saying, what was the diagnosis? Saying what I need to know. Okay. Yes, here we go. Mr. Back, please. One. Is this the first? Oh, yeah. Okay. Forward one again. I'm sorry. Poor Fide. She's got to deal with this every day. Mr. Lavrov is examined for new onset COPD. He is noted to exhibit an FEV1 of 672, meeting criteria for moderate gold COPD, and is scheduled confirmatory x-ray. This is something, you'll read it in the medical note. It says this. These words are a big deal because this is a patient with an extensive smoking history that does not have a history of COPD, that now just passed a screening criteria. That means that we have a new diagnosis. All you need is that FEV1 to put it on paper, and you send him for a confirmatory x-ray to confirm the diagnosis. This is a patient who is entering into a new phase of their life where they're going to need increasing respiratory and physical support. So, next slide. So, and I'll stop with this, and we won't do the question for time, but I'd like to, as we're thinking about this new diagnosis, COPD, what does it mean? This is an obstructive lung disease. Now, there's two types of lung diseases. And next slide, please. Restrictive and obstructive. Restrictive stops from breathing out. Obstructive, the lungs become so like an elastic stretched out too much that the patient literally can't circulate air appropriately. The alveoli get big and vacuous. Basically, the breathing engine stops working. It breaks down. So let's look at this patient's social support, social issues, and put it into context here as we wrap up. So Mr. Lavrov worked as a welder until 3 months ago when he was laid off. He has 2 months of unemployment available. His truck is unreliable. He uses Uber and walks for transportation. He has a family history of lung cancer. He has never been screened for lung cancer. He is taking a half dose of his prescription medications because he can no longer afford the medication. Well, that certainly explains the blood pressure now, doesn't it? He has been intermittently homeless since last month when he lost his HUD-supported housing due to non-payment. Now, this one is going to be a surprise when you read it the first time, but just because you're getting a HUD voucher doesn't mean that's secure if you stop paying it. These patients, very commonly, when they do not pay their rent, they transition to an unhoused state. And if you consider someone who has a history of smoking and a history of responding to that stress, to the stressors in their life with smoking, trust and believe that his smoking is going up. Next slide, please. And I'll just to get back on our SCOH screeners, they are to be taken on the intake, and after the consultation, the patient is referred to social services, and another screener is done, and that social services professional, our Iberas of the room, addresses those issues one by one. And I'm going to end that by saying thank you for joining my exercise. It's been a pleasure to have you as colleagues, and I will pass it off to whoever is doing our closing. Fide, Elena, do you want to close it up for us? Give some final words.
Yeah. All right. So here we have some of the resources that we'd like to share with you all. And please complete our post-evaluation survey at the end of the session. And also the slides and the recording link will be sent to everyone after the session. And thank you all for joining us today, and have a great day.